My name is Gail Downey. I'm a journalist and a filmmaker. Welcome to this public consultation here in Chipping Norton. I am an independent master of ceremonies, I guess is probably one way of looking at it today. And my job is to make sure that the questions that you want answering are answered here by the panel who've come today to answer those questions. We have a set amount of time between 2 and 4 o'clock. Ignore that clock there, it's completely wrong. If we can get through as many questions as possible. I've also got in my hand here some written questions. Thank you very much to people who started on that. If you feel you don't want to put your hand up, please do write them on a postcard. Our volunteers, if they can look at the back there. There we go, lovely. We've got volunteers at the back, thank you, who will take the questions from you and bring them up to me and we'll read those out. We have a list of the frequently asked questions on the website, and any questions that we don't get to, they will be put on the website after the meeting. A couple of bits of housekeeping. Fire exits, emergency exit here, and also that one there, which at the moment you came in through the other way, I gather. Is that right? Came from downstairs, so out that way. There are toilets in the building which are downstairs as well. We have a microphone which works, and that will be taken around to you by our volunteers. Just give us a chance to get the microphone to you so that everyone can hear what your questions are going to be. And please, please, please let people speak on the panel, as they will listen to your questions as well. Health is an incredibly important issue, and it's important that all of you get a chance to have your say and get the questions answered. We've got the 2 MPs here, if you'd like to identify yourselves. Thank you. Which is Victoria Prentice, who represents Banbury, and she was at the Banbury meeting, and Robert Courts, who's obviously the local MP for here and for Witney. So if we can start by the panel introducing themselves, so you know who you're talking to, you'll know their experience in the health service. If I start in the corner there. Hello.
Hello, my name's Shelley Hales. I'm a local GP. I've been a partner in Banbury for over 15 years, and I also have a role with Paul working for the local commissioning group. I've lived in Oxford nearly all my life, had all my children here, and I continue to work in this area.
Good afternoon, I'm Paul Brennan. I'm the Director of Clinical Services for the Oxford University Hospital, and I'm basically responsible for running the hospital services on a day-to-day basis across all our sites, including the midwifery-led unit here at Chipping Norton.
Hello, Diane Hedges. I'm the Chief Operating Officer at the Clinical Commissioning Group. Worked in the NHS a long, long time. Started my career in the NHS working in a GP practice just over the border in Berkshire.
Okay. Paul.
My name's Paul Park. I'm a GP in Banbury. I've been a GP in Banbury for 8 years, and I've lived in Oxfordshire for 13 years, and I'm the Deputy Clinical Chair of the Oxfordshire Clinical Commissioning Group.
Hi everyone, my name's Catherine Stoddart and I'm the Chief Nurse for Oxford University's Hospitals Foundation Trust. I don't think I can hide that I'm Australian, but I have been involved and led midwifery-led services for over 20 years, and I hope I bring that expertise to the table.
Okay, lovely. Just to let you know that this meeting, the audio of this meeting, it's not being filmed, but the audio is being recorded for this meeting. There is a hearing loop which I'm told is working. If anyone is using the hearing loop, can they hear? Is that all right? Lovely, thank you. If there's any issue at all during the meeting, just put your hand up. We've got very clever technical audio people at the end who'll make sure. Yes, hello. Yeah, I will as soon as the presentation starts. I will get right out the way. It's not about me, it is about the presentation. Okay, all right, so we'll move on then to the presentation, and if we can ask Diane to make a start.
Thank you very much. So if I stand here, I'm not in the way of the screen, am I? Okay, good, thanks. We're hoping to get through the presentation fairly swiftly. A few minutes from me, and I'll hand over to Dr. Paul Park. A reminder why we're here. This is a public consultation. It'll last for 3 months until the 9th of April on a range of services, and I'll explain the scope of those services and in particular why we've got this consultation, and we're expecting to continue to engage with the public and continue to consult with the public over the next few months. The range of services that we're consulting on in this part of the consultation is the use of hospital beds, the number of beds we have and how we use them, planned care at the Horton Hospital. The terminology planned care really covers things like diagnostics and when you go to see a consultant specialist and outpatient appointment. Acute stroke services, the critical care services that are at Horton General, and maternity services, in particular the obstetrics element of maternity services. There will be a second phase of consultation, which I'll touch on in a moment. The reasons why we're out to consultation, in this first phase, there is more imperative around the clinical and safety side of things, but there is a whole range of drivers of why we're looking at change in the health service. You will have been hearing nationally the range of challenges that we equally experience locally. Those are increasing, and the really good news that we've got a growing elderly population, but a wider range of morbidity, a wider range of conditions, and in fact more and more things we can do, which is great. But we have pressures emerging from the amount of activity. But in this particular consultation, what we want to talk to you about are some of the real clinical drivers that are driving our case for change for this particular part. Why are we doing the consultation in two parts? Okay. It won't be, but I should make sure I say the words that are on the slides, and there's not a lot of words. So just quickly on that, if I run round the loop, I won't expand on it, but the top left piece is the workforce that we need to deliver the services. The middle one is the demand for services. The right-hand one is for the financial pressures that we feel within the health service. We get enough, we get money, we get growth, but we get more activity coming through. The quality of care, our clear ambition to drive prevention and ensure that we're actually investing in prevention to enable people to live longer and happier lives, but by us making sure that we support you with the prevention side. Inequalities. There are some big inequality differences between some of the richest and the poorest wards that we have in Oxfordshire, and we need to shrink those inequalities. And estate and infrastructure. You'll be well aware that some of the infrastructure we've got either in the Churchill or in the Horton hospitals really needs updating. So to go back to why is this consultation in two parts? What we're consulting on in the first part are those areas where there is a real driver for change in terms of the clinical quality. We've had some temporary closure around the maternity services in the Horton, as you'll be aware, and we need to come to resolution about those services. So what it says on this slide is there's a large number of services we need to consult on in total when you look at the changes we need to do. Focusing on phase one, acute hospital beds, maternity services, critical care and stroke, and the important issue of our opportunity to see more and more people in the Horton. We're recognising there are tens of thousands of people that we could actually serve more locally through diagnostics and outpatients. So what do we want to do for the future? In this particular consultation, we're driving that quality driver. But as we're looking at that, we're looking to have the right diagnostics in the right place. So when I referred to the opportunity around planned care, more outpatients, more diagnostics, more ability to avoid those travel times for people going down to the John Radcliffe to get those sorts of services. We have really started to work harder around the way in which we can offer alternatives to admission to hospital care, ambulatory care, and doing more and more of that is where we need to get to, where we've started off well. Making sure that you're in your own bed and that we're supporting people to be at home wherever we can. And some of the startling statistics that you may or may not be able to read on there, but this clearly researched information around 10 days in a hospital bed can be the equivalent of 10 years in mobility loss. A very striking figure, and we have too many people at the moment waiting in hospital in that situation. I might ask my colleague to come back to that in a moment, make sure the definitions are correct, but ideally it's getting people home and supporting them through diagnostics and assessments rather than using beds as a solution. And then finally, technology to support all the ways of supporting diagnostics. So I'm going to pass over to my colleague, Dr. Paul.
Hello. Let me step away from the screen. Okay, can everyone hear me at the back? Yep, and generally? I'm glad to say that the issue with the text won't be such a thing from now on because it's basically going to be videos. I'm simply going to introduce several videos about what we're doing differently. And the first one is about using hospital beds differently, which is basically about how to improve, for want of a better word, and this is a bit of jargon, the flow of patients when they come through the door, through hospital, out again, and care for them properly in the community and preferably in their own bed if at all possible. And that's kind of key to all the things that we do in what we call urgent care in healthcare, because ultimately you can't afford to get people to get stuck in the wrong place, certainly in hospital where, to be honest, it isn't very good for them. Anyway, I'll let the video speak for itself.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, well, just thought it'd be good companionship for you, nice and sleepy together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The Liaison Hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The Liaison Hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
Okay, and just to discuss what our preferred option is, it's basically, the Liaison Hub, of course, is not the only part, but a major part of what we're doing. But it's basically about making sure patients spend less time in hospital and more care is delivered close to home, and more investment in care, therefore, outside the hospital, in whatever setting, and making sure that patients are essentially cared for and with the highest quality and most safety in the right environments for them. The next video is about planned care. Which, again, is a bit of a jargon term, isn't it? But basically, planned care is everything that more or less isn't urgent. And therefore, it's things like outpatient appointments, scans, X-rays, day case procedures, various forms of surgery, which don't have to be done urgently. And this is a pretty good news piece, really, because we're talking about moving 90,000 such things every year to the Horton, so that people in the north of the county, which is where we all live, don't have to go to John Radcliffe anymore for them. And I think that's a pretty good thing to do, as well as, of course, improving this sustainability in the future of the Horton Hospital in the future.
Planned care is care that occurs outside of an emergency situation. And the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations. And if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis treatments in Banbury, but the plan is to enhance those facilities and increase access to more patients to be treated locally. Patients often have to attend hospital for several different appointments to have their investigations and their outpatient appointments and get their results at the end. So what we plan to do with a one-stop shop is to try and reduce the number of attendances patients would have to make. So although we're trying to deliver care locally to Banbury, we also want to reduce the number of appointments patients have to make to achieve their diagnosis and treatment.
Okay, I think that covers it fairly well. So basically the idea would be to, treat, assess more patients locally, at least in the north of the county. So 60,000 outpatient, up to 30,000 day case and diagnostic appointments, getting more scans to Horton and so on, more planned appointments, tests, treatments, surgery, chemotherapy, all that good stuff really. And I personally love the fact that my patients will not be going down to Oxford for many of these things. That's 300 people a day who won't be doing that anymore. And that's pretty good as far as I'm concerned. Okay, stroke care. The main change here, or what's being talked about, is basically about what you do with people who are seen in North of the county after 4 hours after they've had a stroke or what looks like a stroke. Currently, the plan is that they go to Horton, but that isn't actually the best care according to national evidence. But I'll let the video talk about it.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
Sorry, I nearly spoke into the clicker there for a moment. So as I was saying, it's a lot of it is simply about the fact that stroke care has improved so significantly in the last 10 to 15 years, so that the level, the highest level, which is what we want to give to everyone of stroke care, could be done at the Horton, but really can't be any longer. And therefore, it is our contention that everybody who has a stroke should be taken as soon as possible to hyper-acute stroke unit at the John Radcliffe. And also, of course, people will come back as soon as possible to where they came from, short-term rehab at the Horton, early supported discharge for all stroke patients close to home. Critical care is basically about the critical care unit at the Horton, which basically sees all those patients who suddenly need a lot more care, intensive care, as people call it, in the hospital. And this is one of the issues that's basically about workforce and training. You basically need to see a certain number of very serious patients to maintain the skills to be able to take care of them. And the Horton essentially doesn't see enough. But I'll let the video talk about it.
We have 3 adult critical care units at Oxford University Hospitals, 1 at the Horton, 1 at the Churchill Hospital, and 1 at the John Radcliffe Hospital. I suppose the levels of care reflect the complexity of care delivered to the patient and how sick they are. Level 3, which we sometimes call critical care, are for much, much sicker patients. These patients need advanced respiratory support, which is really the breathing machine, the ventilator. Critical care medicine is like everything else in life. The more you do, the more it becomes routine, and the surprises, the less they become unusual. If, as in the Horton, in the last year we had 40 level 3 patients, that means that's less than 1 patient each week, and in reality probably less than 1 patient a day. And that takes it into the numbers that makes managing them not routine, not normal business. Critical care facility at Oxford, there are about 1,900 patients there each year. So you can see immediately how the care of a critical care patient, which is never routine, but the general aspects of the care of the critical care patient becomes much, much more routine simply by having those numbers of patients.
And that about covers it. Basically, there's a fairly small number of the sickest patients, the so-called level 3 patients in critical care at the Horton, and they'll be better treated at the full intensive care units in Oxford. And the suggestion is that we would have a critical care unit for level 2, which still covers quite a lot of patients who need more intensive care at the Horton. Moving on to maternity. And this, again, is a complex and thorny saga about workforce and training. So I'll let the video speak to it.
We want to provide a high-quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of 2 groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
Okay, and that's quite a big issue. For those who haven't been following it in the papers or elsewhere, as it were, this is basically mostly about the fact that since October last year, the formerly obstetric unit at the Horton has been a maternity-led unit. And that's gone all right, actually. I mean, I work at Hightown Surgery, by the way, just basically around the back of the Horton. It would be quite hard to be closer. And we've seen several women go to John Radcliffe and deliver, and that was fine. We've seen more women deliver at the midwife-led unit, and again, they had very good experiences. And more still go to Warwick, which is actually a nearer hospital for us. And that, again, was fine. It was disappointing that we couldn't recruit, the Oxford University hospitals couldn't recruit the obstetric doctors needed to staff the unit because, frankly, of a national shortage of obstetric units and the fact that you cannot anymore have training doctors who are in training, who are most of the junior doctors in the country at the Horton. But that is where we are. And the plan essentially is for that to continue. There will still be very much choice for women because now in Banbury you can give birth at a midwife-led unit, you can give birth at home, you can give birth at one to two hospitals nearby, and that those are all valid options unless it's not safe for you to do so. Obstetric care would be at the obstetric unit at John Radcliffe. The special care baby unit would be at the John Radcliffe, and some would be transferred to John Radcliffe depending on what happened during pregnancy and delivery. All the documents, including this presentation, by the way, are available on the Consultation website. And so please do that and write to us on the free post address, complete the questionnaire on the website, attend any of the meetings, and here we go to the meetings. There are 12 public meetings like this one happening. One of them's happened already, of course, in Banbury, around Oxfordshire, and everyone is welcome to come and ask their questions and have their say. And that's what we want. We want everyone to come. Well, not all of you, because not all 720,000 people fit into any given venue. But then we want to collect responses, and then they'll be given, by the way, to an external company for analysis. It's quite important that all the stuff that you say is analysed independently of us, and then those results will come to the Clinical Commissioning Group board later in the year, and then that's when we'll make any decisions about what's been talked about today. Thank you very much.
Thank you. And the lady at the back who asked about the light being too bright and not being able to see the font size and so on, that is actually going to be on the website, the whole presentation there. So hopefully you should be able to read a bit better. But actually we will take that on board for the next meeting. So thanks very much for pointing that out. Okay, Roger Courts, Robert, who's the local MP. If we can come to you first for the first question, Robert, just wait till we get a microphone. He's just coming down the aisle to you. Do you all know Robert, your local MP? Yes, no? Yeah, okay. Okay, off you go.
Thank you. Good afternoon, everyone. And thank you very much for organising this meeting, which, of course, is so important to everybody here in Chipping Norton. I'd like to concentrate on maternity services, really, which are of particular importance to us here with the MLU at Chipping Norton. Now, of course, Chipping Norton, as you know, but it's important to emphasise that the distance from Chipping Norton to Oxford is significant. We are talking, on a very good day, a 40-minute journey. The rurality of this area cannot be stressed highly enough, particularly in wintertime. I'm sure everybody here will agree that when we do get snow, here it's particularly bad. You may not get snow in other parts of the country, but you do here because it's particularly high. There are very narrow roads. It's a rural area, and therefore the importance of having maternity services here, rather than having to go to Oxford, is particularly critical. So currently we have an MLU at Chipping Norton, which is backed up by, in theory, of course, obstetrics at the Horton, and that provides a reasonably safe level of cover. Now, we could be told in the course of this consultation that there is going to be an MLU at Horton backed up by an MLU at Chipping Norton, but in phase 2, we're told that that is going to be consulted upon. So we could be faced with a situation here in Chipping Norton where we have no obstetric care within a reasonable distance and no MLU unit here either. So my question is how you can expect the people of Chipping Norton to be reassured that an MLU only at the Horton provides adequate care for them and their children on the basis of there being also a Chipping Norton MLU, when the consultation is that that may be removed. And that, being entirely honest, is what everybody suspects is the case. So how can you reassure my residents, please?
Thank you very much for your question, Robert. In relation to, and I need to get the clarity across about phase 1 and phase 2 of this consultation. In phase 1, which is what we're doing now, what we're consulting till the 9th of April on, is about the obstetric care at the Horton. And the argument that we have, the problem, the issue we all face is the ability to have obstetricians there every day, all round the clock. We are not consulting at this point on reducing the number of MLUs. We need to explore the right shape of midwife-led units in the future in the north. We need to explore that across the county. That is not in question in what we're talking about in phase 1. There will be a midwife-led unit at the Horton, midwife-led unit at Chipping Norton. The issue we have a challenge with at the moment is obstetric care.
Would you like to come back on that very quickly, Robert?
Thank you. I'm sorry. I have to come back on that because that is precisely the point that people are complaining about. I know what you are saying. You're saying this is only about the obstetric care at the Horton, but the point is the services are interlinked. In your consultation document, one of the options that you consider is the closure of the MLU unit at Chipping Norton. So how can you consider the safety of services for the people here and say simply that the future Chipping Norton isn't at question at the moment? It clearly is in question. That's why you've got it as an example.
Thank you, and you're exactly right. We put it there as an example. So when you go back to the whole range of things that we have to make choices on as a commissioning group, we have to look at how we make sure we make the best use of the workforce and the money. In phase 1 of the consultation, we are talking about the obstetric unit. There is no change to the midwife-led units. We could not change the midwife-led units without further consultation. Yeah. So we are talking about the dilemmas that we have in relation to continuing that staffing within the obstetric unit. Phase 2, it may talk about midwife-led units and the shape of those. That is not the case at this point. We're talking about 2 midwife-led units in the north of the patch, to be reviewed when we understand better the number of births that we're having in each and how the midwife-led units are working.
Is there anybody else who's got a question on that same subject? Is there...
Oh, okay.
Just the lady will get to you.
Thank you. Steve Akers, Chipping Norton Labour Party and former chair of SAVE Oxfordshire's Community Hospitals and Services and past convener for Unison at the Oxford Radcliffe Hospitals. The follow-on question has to be to you as commissioners, because obviously with the Chipping Norton audience, we are most concerned to see that proposal about the loss of a midwifery-led unit here. I mean, you've put it in the document, that's why you're going to get questions on it. Yeah. We have lost too much in this town. We've lost our intermediate care beds when the commissioning was moved to the county council, and we discovered that the description of them had been changed. Other colleagues may want to ask questions on that. But my specific question is this, really. And in this sense, as a past NHS employee, I have some sympathy with you. It may surprise some members of the audience to hear that. And it's more of a question to the members of the current government, and that is this. Your consultation document on page 8 cites, and on your presentation, financial pressures as, quotes, funding does not keep pace with demand. Now, if you, as commissioners, had the correct level of investment and weren't being, with providers in the NHS, being required to make cost efficiency savings and cost improvements, i.e. cuts, in the NHS year on year, were they not demanded, would proposals like we are seeing, such as the closure of the ITU, SCABU, obstetrics at the Horton, and the potential loss of our midwifery-led unit here, even be in the consultation? Isn't it a question of adequate investment and resources and political choices?
Okay. Thank you. We'll get Paul to answer that.
Thanks for the question. Very helpful. Yes, there's no doubt that the NHS is facing, a difficult financial challenge, and for anyone to say otherwise, then I don't think they understand the reality. In terms of this consultation, though, I am absolutely clear that the services that are included in the consultation, which are not, as far as I'm concerned, the midwifery-led unit here at Chipping Norton, we're talking about level 3 care at the Horton, we're talking about acute stroke care at the Horton, and then maternity obstetrics obviously with the implications for special care. In terms of money, it is not a money issue. The issue for critical care is very simple. All the guidance, all the recommendations say that if you are operating a level 3 unit, then you should have 24/7 intensivist cover for that unit. We do not have that. We have around 2,000 people a year going into the critical care unit at the JR. At the Horton, it's 40. And of those 40 patients last year who were cared for in the critical care unit, the reality is almost half of them were actually end-of-life care. So you're really talking about 20 over a whole year. Acute stroke, in December, there were 2 stroke patients treated at the Horton. On average, the last 2 years, it's been 70 to 80 patients a year. And as you heard James Kennedy said, again, it is not a financial issue. This is a clinical quality and safety issue. In terms of maternity, it is the difficulty that units are having up and down the country, and we have had here at the Horton, is that if you are going to provide an obstetric service, you have to have doctors. Those doctors have to be there 24 hours a day, 7 days a week, resident, with a backup on call. We cannot deliver that. We have tried and tried. We have kept the obstetric unit going a lot longer than people thought we would do through a range of innovative developments, such as the Clinical Research Fellow Programme that was inspired by Stephen Kennedy from the university, but we now simply cannot recruit those doctors. We cannot have any doctors in training at the Horton because the Horton delivers so few babies that it doesn't meet the requirement for the experience. Training recognition doesn't exist. And then on top of that, in terms of trainee doctors in obstetrics, because of the nature of the specialty, it is becoming less and less attractive, and both in our own deanery, the Thames Valley, and nationally, the vacancy rate amongst trainee post doctors is 25%, and they are the most attractive posts, and we don't even have one of those at the Horton, and we won't get one. So I can assure you that whilst I accept there are financial challenges for the NHS, and that is absolutely true, the 3 proposals put forward by CCG colleagues Clinical Commissioning Group colleagues for consultation, fully supported by the Acute Trust, are on clinical safety and sustainability, not money.
Okay, now I've got a written question here from Sheila Parker, who was a GP in Chipping Norton. Sheila, thank you for this. And it kind of goes along the same lines. You say, I feel to continue to centre everything at the John Radcliffe is a mistake, and we need to upgrade HCH so that medical staff will be attracted to work here. Anything else along those lines? Any other questions on that? No? Okay, lovely. Sorry, lady with the green scarf.
Following on from Dr. Parker's question, do you have any data of the number of women in obstetric need who choose to go to the John Radcliffe, who could geographically have gone to the Horton? And do you know what exactly started this leakage of service away from the Horton? I appreciate that there is a need for a whole lot of clinical specialists for an obstetric unit that might be dealing with difficult cases. But it seems to me that somebody somewhere started the flow slide towards Oxford.
Who would like to answer that, Paul?
Thank you for that question, and indeed for Dr. Parker's question, which are basically along the same lines, I guess. Is there a flow of stuff of activity of services towards the John Radcliffe, and is that a good thing? Speaking as a GP in Banbury, I don't particularly view that as a good thing. But it is something that has become necessary for specific things. To take maternity as a very specific example, maternity basically happened because in 2012, the Royal College of Obstetrics and Gynecology decided that the number of women being seen and giving birth at the Horton was not enough to maintain training at that centre, which means that basically you can't have junior doctors there. If you can't have junior doctors there, it's very hard to maintain a 24/7 rota of doctors at the Horton or at any site as has happened to. If that's the case, then the only thing we could do, which is what we did at the time, is put in basically a rota, and quite a stretched rota, of doctors who are no longer training and therefore didn't need the training, but who weren't frankly who were rather in short supply, even against the national short supply of obstetric doctors around the country, and basically try and maintain that service as well as we could. And it held for 2.5 years, but it was always a fragile service. We always discuss this there's a local meeting called the Community Partnership Network, at which, by the way, representatives of Cherwell District Council and South Northants and Warwickshire, that's right, Warwickshire are there as well, and as well as to Keep the Horton General campaign. And we've been saying for 2.5 years that this is not a sustainable service, and we had to work out some other solution. And eventually, in the middle of last year, we basically lost enough doctors that we couldn't maintain a 24/7 rota. And the only safe option was to make the change that we did, which is temporary, and that's what we're consulting on now. That is a very specific example, clearly. And personally, I'm very unhappy and disappointed about that. I preferred it when my patients could go to Horton, but they can't, and it's no longer safe for them to do so for that subset of women. There's a subset of women who can safely give birth in a midwife-led unit, and plenty of them there are too, can still go to Horton, and the rest can go to Warwick or to John Radcliffe as wished. I think it's also fair to point out that the flow of services is now, we're suggesting there should be in the other direction too, that there should be more clinics, there should be more scans, there should be more procedures and surgery and chemotherapy at the Horton. Like I said, 300 people a day won't have to go down to John Radcliffe under those recommendations. And I think that is a flow of services away from the John Radcliffe towards the Horton, and I think that's a good thing.
Okay, let's hear from another panel member.
Yeah, I just wanted to answer Sheila Parker's question, really, because as a local GP, I think it's important to look at how we deliver care to our patients. And I started working in the health service in 1974, so I can see you're all working out how old I am now. It wasn't quite the time of leeches, but it wasn't long after it. And the thing about it is that the way we deliver healthcare has really, really changed. It used to be that your GP looked after you or you went into hospital. There was a sort of binary choice, really. And because healthcare has developed so much and because the way we look after patients has escalated, there are lots and lots of things now which people continue to go to hospital for, but actually can be delivered much better in the community. So as the planned care clinical lead for the commissioning group, we are looking really hard at moving the traffic away from the John Radcliffe and back up to this area. So it's not only about the Horton, it's also about community-based things, like community-based diagnostics, because the majority of people that go to the hospital go there because their GP's worried about them and they want a diagnostic outcome so that they can decide how to manage them. It's not necessarily that they're going to go in and have a bed. There's a lot of traffic goes up and down between Oxford and Banbury, which is all about getting an outcome first and then treatment second. So we're really looking hard at getting Dr. Parker's idea of getting patients back up into the north and keeping them up here in a slightly different way to the way that care is currently delivered. We're looking at strengthening things and bringing people their care closer to home.
Okay. Victoria, you wanted to come in.
Yes, thank you so much. My focus is to keep as much care as we can locally. So obviously we welcome planned care coming locally, but that doesn't in any way replace the acute services that we feel we need. Now, I think it's important that we get some of the percentages straight. So my understanding is that the Horton provides currently about 30%, so nearly a third of Oxfordshire's A&E. And I'm sure that the people in this room, if they had the sort of injury or problem that needed A&E service, would go from Chippy to the Horton, because geographically that's sensible. Certainly do from where I live. But I am worried by something Paul said, which is that some people had gone to the Radcliffe, but most had gone to the MLU. My understanding is that the figures are that since the midwife-only unit started in October, about 3 babies a week had been delivered in the midwife-only unit, and prior to that, when there was obstetric care at the Horton, 30 babies a week had been delivered at the Horton. So those figures may, of course, vary from week to week, as babies do, but broadly, could Paul confirm quickly whether that is accurate? Because I do think it's important that people understand that low-risk mothers, self-selecting low-risk mothers, may be a very, very small group.
Just to clarify, what I actually said was that among the patients I'd seen at my surgery, which of course is not necessarily representative of the entire population of Banbury or anything like that, a certain number had gone to John Radcliffe, more had gone to midwife-led unit, and more still had gone to Warwick.
Well, I'll come on to my question in a minute, because I won't take up too long. But of course, Warwick is a very long way from Chipping Norton, and that isn't somewhere that people here would naturally go. What I do want to ask, seeing as we apparently can't get an answer to the intractable problem, it seems, of why we can't know the end result of what we're being consulted on while being consulted. We in this room want to know what's on offer. Really, really, will we get an MLU in Chippy and an MLU in the Horton offered to us at the end of all these consultations? But if you can't tell us the answer to that, could you please tell us the answer to, as HOSC this morning agreed to refer the problem of maternity at the Horton to the Secretary of State and the independent review panel, we hope, could you please halt this part of the consultation so that the people of our area will be able to be consulted on the entire issue of maternity? Because at the moment it's piecemeal and it's very, very hard for us to give views when we don't know the outcome of the end results.
Okay. Victoria, thank you very much for that.
I mean,
Paul.
just from a trust perspective, in terms of kind of answering the specifics of your first question, Victoria, then we were seeing around about 1,400 women a year giving birth at the Horton whilst it was an obstetric unit, and looking at the number of women who've chosen to give birth there in the first few months of the temporary midwifery unit, that would suggest that we'll probably be around 200 women a year. So that's what it looks like. In the second part of your question, clearly I acknowledge that the HOSC made a decision to refer to the Secretary of State this morning at their meeting, and we will work with HOSC on the next steps of how that pans out, and obviously the Secretary of State's decision.
Okay, thank you. A written question here from Bruce Parker, which basically says, I had considerable obstetric training for 30 years working in Chipping Norton, supporting the midwives. There were no deaths in our unit during that time. Your proposals are unsafe. So, should I go?
So there is no doubt that midwifery-led care for low-risk women is the preferred option for NICE, who provide the guidance for us. And actually the National Maternity Review last year also supported midwifery-led care for low-risk women. One of the key things is that women have choice. They can choose to have a home birth. They can choose to have a standalone midwifery-led care, as happens in Chipping Norton and is currently happening at the Horton. They can also choose to have alongside care, which is where they perhaps have made the choice to go to the midwifery-led unit alongside the JR obstetrics unit. And for the very small number of women that have high-risk births, there is obstetric services available. So I would support, with great confidence, the skills and expertise of the midwives who are providing midwifery-led care.
Okay. You had your hand up earlier. Was there something you wanted to say? Just bear with us. We'll get the microphone to you and hopefully not wake up.
Leticia Carter, District Councillor for Chipping Norton. I would agree with what people are saying. It's absolutely unsafe to propose taking away obstetrics at the Horton. It will have a very direct impact on midwifery care here in Chipping Norton. People want the choice. I'm glad you talk about patient choice, and they want the choice to give birth and to go to A&E at the Horton. And I really want some reassurance for the public as to how you're going to extend services at the JR to absorb these patients that are supposed to be going up the A40, up the A34, stuck in traffic. How on earth is the JR going to cope with it? How are people going to get there? How is the ambulance service going to cope that is already absolutely under the... they're in such dire straits than they were in the summer. How are they going to cope with this? I'm glad that the doctor there mentioned that his experience is that it's fine, but as a mother who's birthed recently, it's not fine, it's terrifying. And when you live out here in the sticks and you're hemorrhaging at home and the midwives get to you within 15 minutes and save your life, that is the sort of service that we need for our community. And the fact that you're saying you're going to take it away is terrifying for women here.
So just basically, your concern is the journey time from here into...
And the capacity.
And the capacity.
My concern is the journey time, My concern is the ambulance service. My concern is the cuts to patient transport by the NHS. My concern is how the JR will cope with this. We have midwives, we have doctors, we have consultants telling us that it's already unsafe as it is. My concern is how transparent you're being about the midwife unit and what you're going to take away from us. I have a multitude of concerns.
OK, lovely. Thank you very much. Thank you. Paul.
I mean, if I can kind of speak to the kind of specific issues that you raised there, so thank you for bringing those up. In terms of the capacity, we have increased the capacity at the John Radcliffe Hospital. We've also increased the... Yes, we have. We have not had a single mother turned away from the John Radcliffe Hospital. Well, pardon? No, I'm talking about since the temporary closure, because we increased the capacity at the John Radcliffe, and we have removed the elective caesarean service from the delivery suite, so that we have more capacity on there for managing women in labour. In terms of the other components of safety, the simple fact is an obstetric unit without doctors is the most unsafe facility you can have for pregnant women. Yeah. And in terms of capacity of the ambulance service, as I hope you would know, we have a dedicated ambulance that sits at the midwifery-led unit at the Horton in case any women either need to transfer in labour, or if post-birth there needs to be a maternal or neonatal transfer. That dedicated service is there to take the women direct to the John Radcliffe.
OK, just hold on for one tiny moment. Was there anything else you wanted to come back on that? Sorry, Victoria, just...
Yeah. So the ambulance isn't there permanently. And we're not talking about being in Banbury. We're talking about not only birthing, but post-natal care and prenatal care, not just about birth. You must see that these changes aren't safe for a rural community such as Chipping Norton. You must understand that.
In terms of I agree the breadth of care, but the level of antenatal and postnatal care that is provided at the Horton is growing, actually, compared, because that's a daytime service. So we're actually looking to provide more of that at the Horton, so some women who currently have complicated labour are having their antenatal care at the JR, and we're looking to allow that to take place at the Horton.
But women don't want to do that. They want to be able to be seen closer to home.
And that's what we're doing, by having that antenatal care locally, not in Oxford, and postnatal care locally, not in Oxford. In terms of the ambulance, all we have said so far is that whilst the unit at the Horton is temporarily as a midwifery-led unit, we will have a dedicated ambulance. That's what we promised when we made the decision. It is there. It has been there ever since the switch was made, and no decision has been made one way or the other, because what we said at the Banbury meeting was we needed to see the outcome of consultation. We need to hear from what the public and yourselves in all of the meetings have to say about this proposed change, and then the CCG board will then need to make a decision.
Okay,
which
lovely.
May or may not include the ambulance provision.
All right, Paul, thank you. The gentleman at the back there in the suit, we'll just get the microphone to you.
Sorry, this is very quick, but just specifically on the ambulance, you cannot expect the people of Chipping Norton, and the people of Banbury for that matter, to come to a reasonable decision about what's safe for the future of their mothers. When you're saying, yes, it's wonderful, don't worry, we've got this ambulance there at the moment, but that might not be there in the future when you decide to get rid of your MLU here. You're saying one thing in Banbury when you're asked about it specifically at the meeting last week, and then here you're willing to mislead the people of Chipping Norton into believing that an ambulance might be there permanently, regardless of the consultation process, and only answer it specifically when you're pressed by the Member of Parliament.
OK, Diane wants to come in there.
Well, it was only to say that in terms of the decision, when and if we make decisions about changes, the CCG board will make those decisions. That'll be after May, in the summer, when we've considered all the feedback from the consultation. And clearly what we're hearing from the first two events is the importance from people's perspective around that ambulance. By the time we come to any decision-making process, we would be much clearer about the outcomes. Things are being tracked really, really closely at the moment in terms of what's happening, how the changes are impacting on numbers, what happens about transfers, what happens about that ambulance being used, how many times, etc. So I think in terms of the answer to that question would be answered as part of the decision-making process about what is the right shape of services for us to put forward to the board, for us to consider as a board, what set of support services need to go alongside it. And I just would like for the Prior Lady to reassure in terms of I'm picking up an anxiety about changing of services in Chipping Norton around antenatal and postnatal care. And there, again, to rehearse that again, there is not changes on the table at the moment. There are examples given around there might be changes in midwife-led units if we need to consider that in the future. We're not saying we will. It would be very unkind of us to not acknowledge, as we're doing in this room, that having a midwife-led unit in the Horton, numbers are changing. If we didn't acknowledge that those numbers are changing, you would equally be cross with us and say, actually, you're not talking about the whole story. So all we're doing is saying, while things are changing, while we're looking at what we can do to make the safest service for obstetrics, that we need to just make you aware there are these factors of the 2 midwife-led units. So please, and I'm thinking we need to take away from here the need to be really clear about how antenatal and postnatal care is expected. And we focused more on the units and the birth as you've identified, but there's more, I think, that we can share in terms of information about how those things, which actually we're looking to enhance rather than change.
Okay, if we can get Catherine, who's the chief nurse, to come in.
I was just going to comment about the question of clinical safety. During the process of developing the proposal that was provided to the CCG, we asked the expertise of a lot of clinicians, particularly around maternity care. That included obstetricians, midwives, users, and it became sadly obvious that due to the lack of obstetricians that we would have to change that model. It doesn't necessarily sit well with people, but unfortunately we have to change based on clinical safety and quality. The safest thing for low-risk mothers, we know based on NICE guidance and the National Review, is for care by midwifery-led units, and for high-risk mothers to be supported in an obstetric unit. That doesn't mean that we've changed. In fact, we would like to enhance the antenatal and postnatal care close to home. That's a really important part of it, and it certainly is an important part to have your midwife, who is part of your antenatal care, if you're in a midwifery-led unit, being part of your labour. And so that is part of the process from a clinical perspective, and that's what, I guess, the clinicians signed up to in developing this proposal.
Okay, there's a lady there with a leopard print scarf on. We'll just get to you. The lady's got a hand up there.
Hello, Hilary Biles, County Councillor for Chipping Norton Division. I would like to point out that Chipping Norton is also served by many villages that are south of here, so they've got an even longer journey. And many of the villages are rural, so it's difficult to get even into Chipping Norton. But in the wintertime, they manage that. I want to take issue with low-risk pregnancies, because nobody, you might say you know what a low risk, and you're going to have a low risk pregnancy, but in actual fact you don't. And that can be really traumatic for the mother and also the baby. I did the ambulance review in 2007 on this area. The ambulance services are abysmal. They haven't got any bit better, they've got worse, and I'd like to point out that the ambulance that you say is going to be at the Horton Hospital, that others say isn't going to be at the Horton Hospital, if it is there, once it's called out, it's out. It's not there again. So, you need to take that into consideration. But the question I want to ask is mainly based on Chipping Norton Hospital. We talked about intermediate care beds. You've talked about more diagnostics and things. So there are two questions I'd like to ask. Is Chipping Norton Hospital going to get more diagnostics than they have at the moment, more peripheral clinics? And can you confirm that our midwifery unit, which is excellent and held up in great esteem by everybody, will stay? Because on page 41 here, you say it couldn't. And I don't accept that it's going to be in phase 2. Phase 2 is about community hospitals. You've actually said this is based on the Horton, and there's a whole list of things for the Horton Hospital here. And right at the bottom, on page 40, it says keep the MLU. On page 41, it says close the MLU. So I want to know what's happening in Chipping Norton for my constituents here. Thank you.
Okay, thank you. In regard to the midwife-led unit, the consultation at this point is about obstetrics at the Horton. The consultation...
Yes, yeah, it is. No, it isn't.
So, as a result of this consultation and the decision that the CCG will make, assuming we do go ahead and make any decisions, if there were decisions to be made, there could be no decision made about closing a midwife-led unit in Chipping Norton because that is not part of this consultation.
All
As
right.
part of this consultation, it's an absolute guarantee.
All right, lovely. I'm just going to broaden to bring some of the other questions in from people who've very kindly written them in. One here is from the Reverend Stephen Bywater, which is with 2,000 approximate new homes being planned for Chipping Norton and those in Woodstock, many more already being built in Banbury, how are the Oxford hospitals going to cope if the Horton is downgraded? Parking is already impossible at all three, and Oxford is already difficult to get into from this side of the county. Paul?
I thank you for that, and I take that question entirely, which is why, as has been outlined by both Paul Parks and Shelley, a key component of this consultation is the development and building of a new outpatient and diagnostic centre at the Horton, and additional day case provision there, which will mean that around about 90,000 patient episodes for Banbury residents that currently take place in Oxford will take place locally, which will mean less traffic going to Oxford and less travelling for local people.
Okay, another kind of question along the same lines. Anita Hyam, who chairs North Oxfordshire Chipping Norton Patient Engagement Forum. Much of what is proposed for the Horton is promising, but the parking at the Horton will be totally inadequate. What are the plans for that? That runs along the same line, I guess, doesn't it? Catherine?
Part of the process, I guess, at the end of this consultation is to look at the facilities at the Horton in particular and how we can create a Horton General Hospital for the 21st century. And, of course, that includes a revision of our parking provision and as we build a new diagnostic and outpatient centre, what will be required. So part of the whole process in that is actually to develop additional parking.
Okay. A question here from Sue Chapman. Has there been consideration about having some outpatient clinics here in Chipping Norton held either at the hospital or at the health centre? And if so, is this a possibility? If not, why not? From Sue Chapman.
That's a very high possibility because, as I mentioned before, a lot of what we are trying to do is to keep people away from the centre of Oxford. An awful lot of outpatient appointments are first outpatient appointments and they don't need much follow-up if we can get the diagnostics in the right place. At the moment, we're reviewing a lot of pathways with our specialists in secondary care because the current pathway is that you see your GP, they decide you need to see somebody, you go into hospital, they decide you need a test, you come back, you have the test, you go back to hospital. And it's not very clever. It's a lot of driving, it's a lot of anxiety, everybody wants to know what the outcome's going to be. So we're looking at streamlining a lot of the pathways and bringing the diagnostics out, and there's no reason why that can't be locally. We are under consultation for that, and we're looking at getting the best bang for your buck in terms of where we can put those diagnostics and how we can get people through the system safely and quickly.
A question here a couple of questions from Liz Leffman, and forgive me if I can't quite read this right, Liz. What do you see as the role of Chipping Norton Hospital? Will it be, I think this is a liaison centre, in which case will the beds be upgraded and run by the NHS? So it's basically a question about the future of the hospital, yeah.
In terms of changes around any bed-based and community services, that's something we'd come to in the second phase of consultation. So it's not part of the consultation today. As you'll be, or many of you may be aware, there's recently been a consultation about the Chipping Norton beds, and that was concluded. The council led that consultation. And that was concluded, and I'm not anticipating that there's any particular changes around that.
Okay. Yes, of course, yes. And then I'll come to you and then come to the lady at the back, yeah.
I'm sorry, but as part of that consultation, I spoke at HOSC, and I asked that those beds and the intermediate care beds at Chipping Norton Hospital would be included in the community hospital review. Consultation.
Yes.
So, in actual fact, the answer was yes.
Well,
so they should be, because this is really a community hospital. You can't take those beds and say they're not included.
Okay, I suppose I think
otherwise it'll have to go back to HOSC.
Apologies. No, I think what I'm trying to say, and probably putting it in a very clumsy way, when we look at the whole of what we need to do to deliver older persons' care, the support care we need in the community, the rehabilitation, all of those aspects, we will consider all of those things as part of our preparation for consultation. Yes, I think I was at the same HOSC where it was requested that the intermediate care beds go into a consultation. I suppose what I was trying to get at and putting in a clumsy way is one can often assume something going into a consultation might mean it's going to change in a bad or a difficult or an unwanted way. And I don't want you to make that assumption is purely what I meant in relation to that. So as we talk about community services, it should cover all of community services. And what I'd like to reassure people, and I think it may not come across as clearly as it should in the presentation, is the bed changes that we've been talking around in phase 1 are in effect some of the reduction in beds in acute hospital beds, not the community provision, not Chipping Norton. So what we've found through the work in which we've all been involved around the better use of beds, helping people to leave hospital more promptly, is that using intermediate care beds like the sorts of beds you have in Chipping Norton has been something we've found really, really useful. And in fact, we've been over this winter period buying more of those beds, keeping beds open that we had and buying more. So actually, as a way of supporting people home from hospital, they have been incredibly helpful.
Okay, the gentleman who's got the microphone.
Yeah, Gordon Moult, I'm a local resident, not born and bred here, as I guess you recognise from my voice. I have a very simple question here. You've talked a lot about building a state-of-the-art facility. You've talked about the difficulties in attracting talented doctors. You've talked about the 300 appointments that are going to move back up from Oxford, which is welcome news. You've also talked about funding problems and everything else. My question is very simple, Liz. Have you done any work at all in looking at how long it's going to take you to build this state-of-the-art facility and how you're going to fund it? And really to say to you, doesn't it make more sense that in the short term, and frankly I'm not interested in phase 1 or phase 2, I'm interested in today, wouldn't it make more sense to use that fantastic facility we have at the top of the hill in the interim, rather than wait until we have this mythical 21st century, which, given the state of financing in the health service, might be a 22nd century hospital?
All right, Paul.
In terms of the proposed development at the Horton, the diagnostic centre, then the CCG had to go through a process in order to allow it to go out to consultation, and that included the financial affordability. So the plans for the development at the Horton are, they are affordable within. We would be looking within a 3 to 5 year period for that facility to be fully operational if the outcome of consultation is that development should propose. In terms of your comment about Chipping Norton, I am going to have to own up to a level of ignorance, in the sense that my involvement in the Chipping Norton unit is in the midwifery-led unit, and that's what I know, and that's what I visited to see colleagues there. I don't know the nature of the whole facility, But there's nothing to, if you're saying that there's empty space there that could be used for kind of outpatient type care, then that's something we can look at. But I have to be honest, other than the midwifery-led unit, I don't know the hospital.
All right, Paul, thank you. Do you want...
Just one short thought. I would say to you, 3 to 5 years probably means 7 years, which is a long time. And I would say to you, please, as part of this phase, not phase 2 or anything else, build into your consultations how we can make better use of that facility in terms of it.
That's
okay, thank you very much. Okay, yeah. The lady at the back.
Yes. This is on. Yes, it is. I'm Liz Lefman, and I asked the question about the status of the beds in the community hospital here. The hospital that we have is not truly a community hospital, in my opinion, because the beds are not staffed by National Health Service nurses anymore. And that is a major problem when it comes to treating people coming out of acute beds. I'm not a nurse, I'm not a doctor, but it seems to me entirely logical that if you want to solve issues around bed blocking, then having beds where people can be treated so that they're not taking up acute hospital beds but can be given the level of care that they need is absolutely crucial. Now, I appreciate that we're not talking about community hospitals today, and that's going to come in the second phase. But the two are, I'm afraid, indelibly linked in the sense that if we don't have the facilities in the community to look after people, then the acute hospitals will suffer as they are suffering at the present time. So the question that I have for the panel is this. Do you see the beds in Chipping Norton Hospital remaining at the level at which they're staffed at the moment? Or do you have a vision? And, I mean, the whole point about consultation is that at some point we have to talk about the vision for the future of the health service here. Does your vision include having Chipping Norton Hospital staffed by NHS staffed and available so that people can come out of acute hospitals such as the Horton and the JR and be looked at before they go to their homes where they may not have the support that's needed for them?
You frame absolutely one of the key questions that we really need to wrestle with, which is how do we have the right set of services, the right pathway to support people and promote the greatest level of independence. One of the things, to share with you some of the challenges we've had this winter, one of the things that we have been struggling with is that the pathways that we have at the moment where we identify in an acute hospital setting that someone, perhaps they need to go to a community hospital. We then find that they wait in the acute setting to go to the community hospital. And we've already reiterated some of the fairly unpleasant statistics about how difficult it is to maintain your independence when you're lying in a hospital bed. We need to get people into the most rehabilitative setting. Our experience this winter, which we're now really trying to look into and make sure we understand, is where we have someone and we put them through a pathway that says you go from an acute hospital setting, you wait for a community hospital bed, you go into a community hospital bed, you're in there for 28 days or something, more than the national average sometimes. And then you're still going home with an extremely large package of care. There's something about that pathway that we're delivering that can't possibly be delivering the best outcomes for our patients, for our residents. So it's exactly the question we need to really explore and make sure we get right as we come out to talk to you in phase 2. What are the set of services that we need? How do we help identify patients at the right time to put in the right place? So that's why I said the role of the intermediate care beds at the moment, Chipping Norton, has been a powerful support.
Okay. There's a written question here along the same lines from John Braithwaite, which says, basically, are the CCG and OUHT confident that sufficient intermediate bed residential home and home care capacity can be provided?
We haven't got enough of the range of services that we need to move people on. We wouldn't have the number of people currently delayed in hospital beds if we'd got that balance right around that set of services. So we really do need to look at how we buy a greater range of services.
Okay, that's lovely. Thank you, gentleman at the front. Yep, we'll get the microphone.
I'm afraid I've got it, so I'm going to speak.
You jumped in. Don't worry, it's fine.
My arm is nearly falling off. I just make the point about intermediate care beds. We are absolutely fed up with the service that we've currently got. We had a brilliant unit working under the NHS as a satellite hub under the wing of Whitney. It had shorter lengths of stay than the Orders of St John have, and I get one story after another at the moment of poor care. We need to reinstate the NHS for our beds. It is a cost-effective option, and we know that the Chief Operating Officer at the time, Yvonne Taylor, said there was a viable NHS option available. The only reason we haven't got the NHS is the County Council wanted to subsidise the care home with those beds. My second point is I've just come from the Overview and Scrutiny meeting, and I don't know whether you've already told the meeting, but the decision was taken to refer the temporary downgrade of maternity at the Horton to the Secretary of State for Health, which I think can only be a good thing. I'd like to ask a question on maternity, bearing in mind that figures show that if you close maternity in Chipping Norton, the savings are negligible within the overall scheme of things. Did the proposal to consider closing Chipping Norton come from the Clinical Commissioning Group or Oxford University Hospitals?
Okay. Diane's given us... Go on, Paul, you answer.
As far as there is no proposal to close the midwifery-led unit at Chipping Norton.
Okay, all right. Gentleman at the front, and we'll just get the microphone to you this time. Just hold on for a second.
Steve Akers, Chipping Norton Labour Party. Commissioners, regardless of the answer to Clive's question as to who posed it, as somebody who's been fighting for the retention of services in this town for 20 years, and on behalf of the Labour Party, and if I could say there's going to be cross-party consensus on this, but on behalf of the Labour Party, I would call on you to do two immediate things. One, to remove the example, which we all think has great danger of becoming a proposal, but to remove the example of taking away the midwifery-led unit, the Cotswold midwifery-led unit, for all of the cogent reasons you've heard this afternoon from my colleagues in other parties. But we in the Labour Party say drop that proposal now, remove the proposal, and I strongly support what Clive has just said. We need to reinstate those intermediate care beds into the NHS forthwith. That's our contribution to this consultation. Thank you.
Thank you very much for that suggestion. And I think I know that this doesn't go down well, but you use the word example and then you use the word proposal. There is no proposal.
I'm citing your document deliberately.
Yeah. Example. Exactly. That's exactly what it is.
The great danger is it becomes a proposal.
Right. Yeah. And as I tried to explain earlier, and maybe didn't explain particularly clearly, is the issue is, as we really know we need to look at the obstetric unit. As Paul has said, it's the most unsafe thing is us retaining we've got an obstetric unit and we can't safely staff it. So we have the obstetric unit issue that this consultation is about. The obstetric unit changes will bring the opportunity of midwife-led, clearly already has midwife-led services at the Horton. We have midwife-led services at Chipping Norton. You would have been frustrated if we hadn't flagged up later on when we said, actually, with the numbers of births that are happening, is it the right thing? That's not to presuppose any conclusions. All we're doing is saying there will be, and there is at the moment, 2 midwife-led units. Those 2 midwife-led units are there. They would have to be a public consultation to change that. It's flagging up is that awareness that numbers are changing. So that's all it's trying to be. In relation to the intermediate care beds, what we will do as we are doing the public consultation on phase 1, obviously we're going to be talking and exploring the community service range that I've just talked about. Clearly, I'm concerned to hear comments from the back of the room that there are concerns about the quality of care, and what I'd rather do is, if we can collect those concerns and investigate those and follow any of those through, to make sure that if there's anything that needs looking at in relation to that. As we look at what we're doing for the range of services in the community going forward, we absolutely will look at the intermediate care beds and whether they are delivering the right range of services. And I think the proposals that were starting to be explored was whether you had a mix of bed-based and home-based intermediate care. And that was some of the examples that Yvonne Taylor was thinking about. And obviously we want to continue to think about those sorts of examples.
Okay, lovely. I've got a handful of questions here about money. If new hospital facilities and buildings are required at the Horton, how much is it likely to cost? Who's going to pay for it? Another question, lack of money. We all see waste in the NHS, 20,000 operations cancelled at the last minute, waste of time and money. And another one about drug companies increasing their charges. The NHS didn't notice, why not? I don't know that the panel can answer the questions to the last one, but I think, Paul, you talked about this was not about finance. This were very clear. There were clinical reasons for these proposals.
Yeah, I would again reiterate there is no financial gain from any of the proposals that we're talking about. The level 3 care and the acute stroke proposals to move to the John Radcliffe, they are based purely and solely on clinical safety grounds. They are not based on financial grounds. And the obstetric proposal is based on the fact that you cannot run an obstetric service without a guaranteed 24/7 medical presence resident on site, and we cannot provide that. In terms of the question about the new development, I mean, we are looking at what the options are, but in our original proposal that we had to submit to the CCG for consideration before they then embarked on the consultation, then we were talking around about £14 million for the development of the new diagnostic and outpatient centre at the Horton. And that is, I understand the scepticism, but that is within that 3 to 5 year period. But that's what the proposal contained.
Okay, lovely. There's a gentleman in navy, but I think there's another gentleman further up who wanted to ask a question. No, that's fine. Okay, thank you.
Thank you very much. Guy Wall, District Councillor in Chipping Norton and also Chairman of the Conservative Party in Chipping Norton. I'm not going to apologise for going back again to this consultation document. It clearly says the options here, the options, on page 40. Following on from that, it does indicate, and I'm going to read it out because we wash over it, we go back to it, we wash over it. It clearly says, close the midwife-led unit in Chipping Norton Hospital. If the basis of this consultation, the paperwork you put in front of everybody, isn't right, it should be withdrawn straight away. It's unacceptable to stand there and say to us, oh, no, that might be an option later, it might be an option later. It says the options are here. It's unacceptable.
I think the words that are used are, this is an example.
No, they are.
I clearly hear the concern in the room. We will obviously be taking this back. We'll relook to see that there hasn't been any. So I will reiterate this consultation. This consultation assumes 2 midwife-led units, 1 in the Horton, 1 in Chipping Norton. I hear the concerns. We will relook at the document. We'll have another look and see if it's misleading in any way. But in terms of coming to this room, you asking me the question, me answering your question, my answer to your question is, in this consultation, there are 2 midwife-led units retained right through the consultation. This is not a decision about numbers of midwife-led units in this consultation.
Okay, Paul.
Could I just say, I understand the concerns that you're raising. Clearly we'll take them back, but can we be absolutely clear from both the Clinical Commissioning Group and from the OUHFT, as the provider of a midwifery-led service in Chipping Norton, it is staying. The outcome of this consultation will not. No, I'm saying from this consultation will be no change to that provision. Well, I don't know. I don't know what that second consultation will be.
So in the autumn of this year, you're guaranteeing at the moment that they can keep their MLU until the autumn of this year. Is that what you're saying?
As far as I understand it, I'm completely independently chairing this, is that there are going to be 2 phases, and the second phase will discuss, am I right, the MLU? Is that right? That's right. That's right. The team here will take that back. But, however, you could also, and they'll let me know if it's different, but you can also make your views known on the website.
Yes.
Is that right?
Yeah.
There's a lot of strong feeling about it. We've only got till 4 o'clock. So what I'm saying is, yes, carry on voicing your opinions here. That's great. That's what they need to hear. But please, 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 go onto the website as well and make your views known. Is that fair, Diane?
And just to answer your question about the autumn, actually, the autumn would be the start of any next consultation. So actually, there's a whole period of consultation and decision-making. So actually, there would be, even if there was a change, we wouldn't be talking about until 2018. And I don't think we're even saying that there wouldn't be a change until such time as anything was proposed.
Okay. Can I just read out a written question here? Would the panel like to confirm, as told in Banbury, that the NHS will buy the Ramsay Centre so it doesn't have to be closed in July and that jobs will be saved? Does anyone want to answer that? Oh, sorry. It's will the NHS buy the Ramsay Centre so it doesn't have to close in July? I don't know.
I can answer that. The building that is on the Horton site is used by Ramsay on a lease, and that lease will come to an end either in July this year or March next year. And when that lease comes to an end, the facility automatically comes back to the NHS. It comes back to the Oxford University Hospitals NHS Trust. So it's not a question of buying. It will become back to the NHS.
Okay, thank you. The gentleman, you put your hand up over there. There you go. The microphone's just coming to you. There you go.
Thank you. Dave Winpenny, a resident. I find it interesting that you muddy the waters between Phase 1 and Phase 2. We've just heard an announcement that our MLU is not going to be affected, but that makes no reference to what happens to Wantage and Wallingford. You said that the MLU in Chipping Norton would stay up, so I assume that Wantage and Wallingford have just been closed down.
No.
My questions are simple. Why can't you change the scope of the consultation at this level to include this whole MLU thing so that we get clarity once and for all in Phase 1?
So the answer in relation to Wantage and Wallingford would be exactly the same as the one I've just given around Chipping Norton. The MLUs, as they are in their current form, will continue until such time as there was any proposal that came out that said they should change. If there were to be a proposal, we would likely build that into a future phase as identified from the autumn. So it's not to say anything's changing at this point. All MLUs continue to work as they currently are. In relation to your question about why we've had to do the 2 phasings, there's such a lot of work that has to go into preparing the overall proposals that we need to put forward that it was becoming evident that there was more and more that we needed to do about the community side, including some of the community hospitals and where midwife-led units are in them and those sorts of things. We couldn't do all of that without holding back some of the really essential things we needed to talk to you about now, which are the obstetric service, the stroke service, the critical care unit. We had this debate, we even had this debate with the scrutiny committee, and I think all of ourselves, and most particularly the clinicians, are really clear that we need to move forward on some of the proposals that we're putting forward today. Around stroke care, for example, we really know we could give a greater quality of care if we can get on and make those changes.
Okay, Dr. Paul, wanted to come in.
I just wanted to, I'm sorry, it's terribly clumsy to read from our own document, but actually on page 40 it says pretty clearly, we are not consulting on this proposal responding to MOUs now, and the CCG will include firm proposals for all Oxfordshire MOUs in phase 2 of the consultation. That is that. Nothing's changing. The fact is that we have to make any substantive change at any community hospital, whether it's the midwife-led unit or whatever you want to do, then you have to consult on it. And we're not consulting on it now. We'll be consulting on it in the second phase. The reason why we're not doing it in the first phase is because there's quite a lot to do, frankly. And there are certain things you have to get done early in the year, especially using beds better and the obstetric unit at Horton, that we're pressed, especially by the Health Overview Scrutiny Committee, to get done soon. That's why we're doing it now. And then there'll be a second consultation, basically for all the community hospital stuff and services, including midwife-led units, if that's what we're going to talk about then. And basically, does anyone remember the big conversation last year where we went out to a lot of places, we asked a lot of questions about how do you want things to be? We didn't make any suggestions, we just asked what you wanted. A lot of that, and that took quite a while, a lot of that has shaped this consultation in roughly the same way that this consultation will shape the second consultation. So it's just an ongoing process of asking you what do you think the best options are. That's how consultation works.
Okay, thank you. The lady at the front.
Really glad Dr. Paul's pointed out how a consultation works to us all. Just to point out how it works to you, hundreds of women have been excluded from this consultation today because of the choice of the time, 2 till 4. I'm sat here in the stressful circumstances of having my 2 children, but a lot of people can't do that. They're either picking their children up, they're working, or, they're at home with their children because they couldn't cope with the stress of being here with them. I'd just like to ask also why we have 4 bouncers on the door. This sets a horrendous tone for the people of Chipping Norton. I've never, in my 15 years of attending meetings or organising them for the NHS, in the last 8 years I've worked for the NHS, commissioned and paid for a private security firm. It really does set a bad tone. It is a waste of money, as are the consultants that are putting together this consultation. That does not make sense to us, and it's very confusing rather than clear. I still haven't had my question answered about the JR and how A&E is going to be extended, parking is going to be extended, midwifery is going to be extended, surgery is going to be extended. How are you going to absorb the changes long term? I know short term you say it's not been an issue, but long term I really think it will be for patient safety. And when you go away from this consultation today, I want you to be clear that people of Chipping Norton value A&E at the Horton, we value obstetrics at the Horton, we value SCABU back, please, special care unit at the Horton, we value the Children's Hospital at the Horton. We want these services close. We do not want to be shipped off in ambulances to Swindon, to Gloucestershire, to Warwickshire, or hell knows where else. We want our services where we can use them.
I mean, again, I can only come back to there's no proposal around the emergency department or surgery or whatever. I mean, in terms of surgery, all, other than trauma, all inpatient surgery takes place at the JR or the Churchill or the Knock. We don't do general surgery or specialist surgery at the Horton and haven't done for a number of years. In terms of, and as I say, the A&E is not, there's no proposal to change the provision of A&E. I understand your concern around obstetrics and the fact that we have had to temporarily close it and that this consultation is proposing to make that permanent. But the simple fact is that an obstetric service can only exist if you can guarantee every day, 365 days a year, that there'll be a doctor there 24 hours a day, and we can't. And to have women who are not suitable for a midwifery-led unit going to the Horton for a higher risk birth, that would be a major patient safety issue. And the only reason the Trust Board made the temporary change was because it's serious concern about safety, and the proposals contained in this consultation in relation to obstetrics are solely around safety.
Okay, there's a written question here around the similar subject from Lorraine Bartholomew, which says basically, why can there not be a system of rotation of the obstetricians from Oxford, presumably into the local area and to Banbury?
We can't do that because the junior doctors at the John Radcliffe Hospital are doctors in training. They are training doctors, and they can only operate in an obstetric unit that is designated for training. The Horton has too few births, or had too few births before the temporary closure, and therefore junior doctors are not allowed to rotate through that hospital because they wouldn't get the necessary experience and exposure to continue with their training and develop their skills and expertise.
Okay, Catherine, you're chief nurse.
I was just going to comment that, in fact, the changes at the JR in order to accommodate this activity have been successful, and we have been able to manage or cope with that activity. But fundamentally, this is a decision around clinical safety. As Paul said, if we do not have doctors available 24 hours a day, 7 days a week, then it is unsafe for a woman to turn up at the hospital and expect that they will get doctor-led care. It is better for us to triage those women very early on in their pregnancy, midwifery-led care. The language of triage is not great. So determine at the time what is the right choice for women so that we can then streamline them into the right care that they think they need and that we can provide for them. It's much better to do that than to actually do that late in their pregnancy. And so we're really... Part of this is about making sure we have really strong antenatal care close to home and really strong postnatal care after women have delivered their babies, after they've made a choice about where they want to have that birth.
Okay, just to come back to a couple of points you raised there, a number of other people have asked the same question in a written form. Why is the meeting being held in the afternoon when so many people are at work? Not very convenient for a public meeting. I know that there are a lot of public meetings going on around and at different times, but if I could ask the panel, why this afternoon, why not evening time, and how does it work across the county?
Okay.
Yeah. Sorry. Hold on, one question at a time. Hold on for a second.
Thank you. I just wanted to... I'm not sure who just made that point, but I entirely agree with you, and I agree, of course, Letitia's made this point now. This meeting, I've made the point in the strongest terms to you, as you'll agree, a meeting on a weekday between 2 and 4, when all manner of people, for any number of reasons, cannot come here, is just not good enough for you to be able to have your say. Now, I will hold another meeting, which will be on an evening or on a weekend. I've invited the CCG. I hope they come. But if they don't come, you can, and I will report back what you say to them.
Okay, thank you. Yeah. Okay. We'll just get an answer to the question about why daytime and where they are. Meetings are across... we'll get to that bit, hold on, across the county.
Okay, thank you. Well, deliberately, it's a mix of daytime and evening to make sure people can make those choices. Obviously, people are very welcome to come. People are very welcome to come to either...
Let her answer, because you've asked, if you don't mind.
People are either obviously very welcome to come to any of the combinations of sessions. I know, Robert, you were planning to have another discussion locally, and we talked about having that before, so maybe we should continue that conversation about when. I think the issue will be making sure we can mutually find a date that's acceptable. Yeah.
Okay. The question of the bouncers at the door. Did you say there were 4? No, sorry, I should ask you.
I think in relation to this, it's something we're putting on each of the sessions that we've had. We've launched this consultation. We've had a couple of meetings. It's going to happen at every one, or maybe we'll decide that it's not inappropriate and not needed. But it's not. No one's been singled out.
Okay, just bear with the gentleman there has been incredibly patient with his hand up for the last 10 minutes. If we can get to your question, please. Just hold on, let the gentleman ask his question.
Yeah, thank you. I mean, I've appreciated what you've said this afternoon about future services, etc. One thing I've not picked up at all, and that is that a real consideration of the exponential explosion in population that this area is about to have and is already having. How is that being factored into your plans?
Okay, who would like to take that question? And that's did you ask a question about the 20,000 new homes? Was that your written question? 2,000, sorry. My maths has never been that good. Yeah, okay, the 2,000 new homes, yeah.
I mean, in terms of the population increases, I mean, again, I would come back to what is in this consultation, and that is about centralising 2 services, critical care level 3 and acute stroke, on clinical safety grounds. The population changes are not going to change that. The simple fact is that if you have an acute stroke, you need to go to a hyperacute stroke unit. Yes, and that is part of the development of the services at the John Radcliffe to be able to cope with that. In terms of obstetrics, and I know every time I get asked this question, I give the answer and then everyone laughs at me, but I can only give the answer from the work that colleagues have done. They've looked at the population demographics, they've looked across Banbury, in Chipping Norton, in Bicester, on all the housing developments. This has not been done by the Trust, this has been done by the County Council, and their analysis of that demographic says that the impact of the growth on birth rates is less than 1%.
Okay.
That is the independent analysis done by the County Council.
Okay.
Can I speak?
Okay. We've got probably 5 more minutes, and I'm conscious there are a couple of people, gentlemen at the back there, who haven't had. Bear with me, who haven't asked a question yet. And there's also a lady. Bear with me. There's also a lady in pink. Is that right at the back? Somebody put their hand up. Lovely. So if you can go first, then the lady in pink, and then the gentleman there. That would be great. Thank you. Fire away.
Thank you for that. The point I was going to make, Dr. Park might like to know, we didn't have a big conversation in Chipping Norton. We asked for one in September. We were promised one. But despite our repeated requests, the CCG never gave us a meeting date. Then in November they said, well, it's too late now because the consultation starts in January. So the options were determined with nobody having a public say in Chipping Norton, which I think is disgraceful. Okay. I just want to say to people in the room, fill in your consultation replies by all means, but don't do it yet. Wait and find out what this really means, because the longer this goes on, I'm sure the worse it will get. There are going to be more discussions on this and more information will come out, and we'll do our best to get as much information out to people as we can. And I do think it's important that you have another meeting. That if you think this is a reasonable turnout, you ought to see it if we get an evening meeting held by Robert, who I think should chair it. And I think it would be shameful if the CCG didn't come along to address a meeting that covers some of the biggest things that are going to happen to the lives of people in this community.
Okay, lovely. So will you now take that back? Is what you said, yeah. Okay. So the panel will now take that back. Okay, lovely. Lady in pink.
It's fine. Oh, hello, I'm Linda. I live in Chipping Norton. I'm not eloquent or as knowledgeable as some on the issues here today. I will pick up that someone on the panel said we are here to discuss the obstetrics situation, but when I came in, which was late, we were also discussing the intermediate care beds within Chipping Norton, which is where I live, and I'm interested in the services offered to the people of Chipping Norton, which at this moment are zero, when we have the facilities to do so. We talk about the Horton Hospital, which is very near to us, easy to access. You state, or the panel state, that your main interest is the clinical care. We have a hospital, in fact we have two, the facilities are there, and I presume there are no doctors. This is why we cannot give the care that you state. Why are there no doctors there? You cannot employ them, and I say you because you are the panel. Could you, the panel, tell me how much you spend on agency staff a year and why that money cannot be spent on employing doctors and nurses?
Okay, thank you very much. Thank you. I think that information is publicly available anyway. I don't know they'll have it off the top of their heads, but you've asked the question, so let's see if we get an answer.
In terms of the trust, across all of our services, our combined bank and agency bill runs at just under £3 million a month, and virtually all of it is spent on bank or agency doctors, nurses and paramedical radiographers because of the level of staff shortages. Because this is actually, for a lot of people, it's quite an expensive area to come to. And so the money we spend on agency or bank is actually spent on doctors and nurses and therapists.
Okay, thank you.
I just want to ask our two MPs...
Just hold on for 1 second, sorry.
I just want to ask our two MPs, as this is a consultation process, which means we're here to talk and listen, if they would like to take back to the centre of government the issues around medical staffing and nursing, because we talk about agency fees, but as GPs in Oxfordshire, we are 30% understaffed, so all GPs are working 50% harder to cover the workload. We are advertising for GPs to come and work, and we can't get anybody in post, and that knocks on, and then there's the hospital issue around doctors as well. And one of the reasons for that is because of the conditions and the issues around the funding to the health service. So whilst we're here to listen to you today and to try and make the funding that we've got go as far as we can, as well as we can, there is an issue for central government as well.
Okay. I've just heard the chimes go, so we've only got time for one more question. I promised the gentleman there. So please, if you don't mind...
Richard Benford, Town Councillor. Is this really a public consultation or not just a PR exercise because the decisions have already been made?
This is a consultation exercise. We had an engagement exercise. I hear about the shortfall in not coming to Chipping Norton. This then moves on to a public consultation. We have to get out and about to as many places as we can. We hear the views. At the end of the day, the CCG board, in conjunction with partner organisations, will need to look at what comes out of the consultation. What we need to do at the end of the day, though, is ensure that we can, and we commission, and partners and the Trust provides safe clinical care to the highest quality. What we are seeking are views through the consultation. What we will need to do at the end of consultation is say, how can we deliver the best stroke care? How can we deliver safe obstetric care? Is the critical care unit as it is safe? So the consultation will hear views. The consultation seeks to consider the proposals we've put forward, which we believe are the best way of delivering that safe care. That is the issue around consultation. We need to look and see if there are different ways of delivering and responding to the challenges we're laying out. We believe the proposals we've put forward are the best ones. If there's better proposals, that's what we need to hear as part of this consultation.
Okay. Thank you all very much. Just very quickly, is anyone from the panel wants to sum up? Is there anything else you want to say? Are you fine? And that's fine. People can put their questions on the website. There also will be a list of frequently asked questions as well. Robert, you say you're going to liaise with the panel to have another have another meeting to talk about it further. Make your views known. The website is very easy to get onto and put any other questions on there. Thank you all very much for coming.